I think that Mindray has done a good job in promoting.
Good morning, ladies and gentlemen, my dear friends. Welcome to join Mindray Critical Care Nursing Series webinars. This is Horace Wong, General Manager of Mindray ASEAN region. First of all, our special thanks to Malaysian Nurses Association and the University of Malaysia Medical Center for co-organizing this mega event with Mindray. And our special thanks to our distinguished speakers from Australia, Singapore, China, and Malaysia to share your valuable experiences. Most importantly, thanks everyone to join us today. As you know, the fourth wave of COVID-19 not only hit Malaysia, but also other countries. Malaysia is again under MCO now. How to cope with the COVID-19 in pandemic and the post-pandemic? What's the new technology and innovations around the world? Based on Mindray's vision, we will make better healthcare solutions more accessible to humanity. So we build this academic platform to learn from each other and find the answers from sharing and exchanging. And our today's topic is technology and innovations in high acuity nursing care. This is episode 2, ASEAN-China fighting against COVID-19. Please allow me to introduce our host today, Ms. Yoga, who is a distinguished collaborator among Mindray, Malaysian Nurses Association, University Malaysia Medical Center, Queensland Government Australia, and the Singapore National University, will be hosting this ASEAN-China webinar activity. Currently, she is a Vice President in Malaysian Nurses Association and stays active with association activities. Ms. Yoga is very dedicated and knowledgeable nurse tutor with more than 33 years of service in healthcare and nursing education. As a nurse educator, she is committed in developing better clinical experiences for students and to be an effective healthcare provider in future. Ms. Yoga has wide experiences as invited speaker or moderator in international as well as Malaysia domestic conferences. Now let's warmly welcome our host, Ms. Yoga. It's your turn. Thank you.
Thank you very much, Mr. Horace, for the warm introduction. First and foremost, a warm good morning to all participants from China, Australia, Singapore, Malaysia, and the rest of Asia Pacific region. Thank you for investing your time with us on this Saturday morning. Welcome to the second series of presentation in collaboration with Mindray, Malaysian Nurses Association, University Malaya Medical Center Malaysia, Queensland Government Australia, and National University Hospital Singapore. The main purpose of this significant collaboration between these organizations are to bring to you the updates of the latest trends affecting health, work environment, process, and system, as well as practices of healthcare professionals. The organizers have invited amazing speakers who are expert in their field with topics tailored based on the chosen theme. Our second series webinar entitled Technology and Innovation in High Acuity Nursing Care, Episode 2, ASEAN-China Fighting Against COVID-19. The objective of the webinar is discuss a new wave of health technology for innovative solutions to address the demands in high acuity nursing care environment in selected Asia-Pacific countries. Discuss the nursing care delivery model to align with the innovative technology and value the significance of harmonizing holistic care with technology. There is an active session in this webinar. Therefore, we request all participants to keep posting questions in the question and answer box. Let's get started. For the welcome speech, we have Madam Sharifah Asya Said Junaid Al-Junaid, President of Malaysian Nurses Association, and Madam Karen Thompson, Senior Director of Health Innovations Investment and Research Office, Queensland, Australia. To formally begin our webinar, we have 4 distinguished guests who will deliver from their respective topic. Firstly, Madam Hasima binti Zainul, Chief Nursing Officer, University Malaya Medical Center, Malaysia, with the topic Big Data Empowers Nursing Strategies to Fight COVID-19. Next up, we have Madam Nikki Dennis, Director of Nursing Services, Queensland Hospital, Australia, who will deliver Battle Against COVID-19 from Nursing Perspective. We also have Madam Ling Huang, Head of Nurse in Critical Care Unit, Guangxi Medical University Cancer Hospital, China, who will speak on acute patient care in hemodynamics. Finally, we have Madam Neo Hui Ching, Senior Nurse of Critical Care Unit, National University Hospital, Singapore, who will take on the role of innovation and technology in the times of COVID-19. Thank you to all our guests and speakers for sharing their experiences and expertise in this webinar. We now move on to our first agenda, the welcoming speech. May I introduce Madam Sharifah Asya Said Junaid Al-Junaid. Madam Sharifah is the President of Malaysian Nurses Association, has over 40 years in nursing profession, vast experience as nursing administrator, and promoted to head the nursing services as the Chief Nursing Officer of UMMC from 2008. Appointed as an operating room personal instructor for many countries, got awarded in many international and domestic activities. May I invite Madam Sharifah Asya Said Junaid Al-Junaid to deliver the welcoming remarks.
Thank you, Ms. Yoga, and good morning, everyone. Distinguished guests, speakers, ladies and gentlemen. It is my pleasure to welcome all of you to this webinar platform regarding the technology and innovation in high equity nursing care, ASEAN-China fighting against COVID-19. First and foremost, praise to Almighty God for giving us the strength and blessing to gather here on this platform this morning. Thank you to Main Ray for the invitation from Malaysian Nurses Association to be a part of this critical initiative. I am honored to be here today virtually meeting those who have been working tirelessly to ensure that the nation continue to be served and protected, especially during this uncertainties time. It is not too late for me to wish all of you on the platform and out there, Happy Nurses Day. WHO declared 2020 as the year for nurses and midwives. Indeed, it was and still the year for nurses and midwives. And 2020 will remain as a remarkable year for all of us. As we know, COVID-19 have changed people's lives and also has changed nursing care, regular works and working style. As we know, in nursing care area, especially in COVID-19, nursing care has become more challenging, faced with more affected patients or the nursing workload, risk, patient treatment, all have been more challenging. In COVID-19 periodical nursing care, there are some obstacles or difficulties that our nursing team is faced with, or there are some issues requesting to be solved. At the same time, the COVID-19 pandemic has affected almost all countries and has made a significant effect on the available healthcare facility system. The COVID-19 pandemic has stolen a year's worth of our productivity, resulting in a health and economic crisis. It has created a high demand for essential healthcare equipment. Medicine, along with the requirement for advanced information technologies application, digital healthcare is a powerful element which can be extremely useful against the pandemic of COVID-19 regarding the assessment of risk of infection and screening of the population. And today, multiple digital health projects based on artificial intelligence, data science, machine learning, or big data are being used across a broad range of fields to predict, explain, and manage the different scenarios caused by the health crisis. With this rapidly changing medical technology and availability of high technology diagnostic and therapeutic equipment, together with changing practice pattern, changing practice pattern of doctors have revolutionized the way healthcare is being delivered today. Thus, during the pandemic, this new practice too have to be learned and unlearn the old practice, which is a hard to go. Therefore, everyone has to be more meticulous. COVID-19 has made every one of us to take a step back and reflect a moment, value and appreciate life. The fear and losing loved ones dramatically have impacted our mental health, but business has to continue as usual or far more demanding with the shortage of staff, equipment, and so on. Therefore, building resilience and sustainability in hospitals has become even more urgent matter in this current COVID-19 crisis. What matters is now how to tackle the multifaceted challenges that are here now and ahead. What is waiting ahead is unknown, and that sends a hammering signal. From now on, the healthcare facilities must be ready to switch to pandemic mode, with case in the face of future crises. The pandemic COVID-19 has proven that nurses play a pivotal role in innovation and technology. Nurses represent the frontliner innovation in many different ways. This crisis is expected to strengthen to the nursing profession's voice in the innovation and policy change and create the changes that our healthcare system so desperately needs. But human touch must still remain paramount therapy. Ladies and gentlemen, once more, we would like to thank MINRE and hope MINRE would provide more of these opportunities and clinical topics and gather clinical caregivers here to share more academic and knowledgeable experience and ideas. And I hope all of you will stay tuned and benefit from this platform. Once again, Happy Nurses Day. It will take some time before we go back to our normal norm. Till then, find your inner strength and be safe wherever you are. Nurses, you are our heroes. No words can express the world gratitude all of you serve the people around you day and night, foregoing your own family and pleasure. We stay home and you stay at work. Malaysian Nurses Association salutes to all frontliners for your dedication and hard work, and have a successful webinar today. And thank you once again.
Thank you, Madam Sharifah, for the warm welcome. May I introduce our second speaker, Ms. Karen Thompson, leading the Department of Health Research Investments, Ethics and Governance for Research, including clinical trials and international engagement, has overseen the construction of Queensland Healthcare Professional Development Consortium and holds the position of Consortium Lead, has held a number of senior positions within the Queensland Government working in policy, research, and health infrastructure and program development. May I call upon Ms. Karen Thompson to deliver her welcoming speech.
Thank you very much for your kind introduction. Madam Sharifah, Ms. Yoga, Mr. Horace, colleagues, a warm welcome from Queensland, Australia. My name is Karen Thompson and I head up the Health Innovation, Investment and Research Office within Queensland Health, which is our government public health provider for the state of Queensland. I would like to firstly thank the Malaysian Nurses Association, the University of Malaya Medical Centre and Mindray for the opportunity to speak at today's nursing webinar, focusing on all our efforts in fighting COVID-19. We are here to acknowledge and thank all nurses for the care, compassion, and the professional care they provide to patients, families, and their local communities. Nurses are making a difference to our lives every day, and especially are so essential in fighting this pandemic and helping our people to live through the pandemic. This critical and diverse work of nurses alongside other healthcare professionals has rightly taken centre stage through the COVID-19 pandemic. Nurses are working in respiratory clinics, COVID-19 hospital wards, and now vaccination clinics to help treat those that have become ill with COVID, and also to help provide protection as our vaccination programs are rolled out across the world. Today in Queensland, we are very fortunate in that we only have 13 active COVID-19 cases in our hospitals, but we all know that that can change very quickly. In Queensland, we have a population of 5 million people. Since the pandemic started, over 50% of our population has been tested for COVID, and we are at the early stages of rolling out a vaccination program across Australia. So this webinar today in episode 2 is very important for all of us and provides a great opportunity to hear from nurse professionals from Malaysia, Singapore, China, and Queensland, Australia, on their experiences and achievements in fighting against the pandemic. Geographically, Queensland is the second largest state in Australia with 5 million people. We have a long-standing history of collaboration and friendship with China and the ASEAN nations, including Malaysia and Singapore. Our aging, decentralised and multicultural population brings challenges to health service delivery. So we are constantly working to address these challenges through innovation, systems improvement, technology, and research. And there has been no bigger challenge than experienced over the past 12 months with COVID. Our aim is for Queenslanders longer to be the healthiest people in the world by 2026. And our system has faced many challenges since March last year in providing services to our community. And we have seen a number of changes in how we deliver services, including a significant increase in the provision of medical care via telehealth. So it has been important for us to embrace innovation and change. Queensland and Australia's healthcare system ranks among the best in the world. We are recognised in Australia as leaders in innovative models of care. Our nurses are highly qualified and care for patients across all medical fields. And this is supported by a world-leading education system and strong research capabilities. Queensland is the home to a number of world-class health precincts, digital hospitals, universities, and medical research institutes. For example, the University of Queensland ranked amongst top 50 universities in the world. The School of Nursing and Midwifery of our Griffith University ranked first in Australia and second in the world on the 2020 Shanghai Global Rankings in Academic Subjects. Queensland is a centre of health and clinical research excellence with nursing capabilities, including in acute and critical care, infection prevention and control, and emergency management. Over a century ago, one of the world's most well-known nurses, Sister Elizabeth Kenny, developed an alternative approach to polio treatment here in Queensland, and this became worldwide known as the Kenny method. Just last week, a research project on the effects of nurse-to-patient ratio legislation on nurse staffing and patient mortality, readmissions, and length of stays in hospitals, led by our Queensland University of Technology, was published in The Lancet. This very important research project that really was looking at quality of care involved over 17,000 nurses and 400,000 patients. And it showed that our policy setting on minimum hospital nurse to patient staffing ratios has saved lives, improved care, prevented readmissions, and shortened the length of hospital stay for our people. This is just one of the many research projects that shows the value of research has on and how it impacts on patient care. My colleague, Ms. Nikki Dennis, will speak to you later this morning. Nikki is the Director of Nursing in our Metro South Health System, which provides care to over 1 million Queenslanders in the southeast of the state. Nikki will provide some details on nurse-to-patient ratios in Queensland hospitals in her presentation. She will also talk about some of the nursing perspectives and innovations that have come through in how we have provided ongoing medical care throughout the COVID-19 pandemic. The Queensland Government supports healthcare international collaboration. We are eager to learn from you and work together to improve our health systems for better health outcomes for all our communities. Finally, I would like to once again congratulate the Malaysian Nursing Association, the University of Malaya Medical Centre, and Mindray for organising this event this morning to talk about COVID-19. Thank you for inviting Queensland Australia to participate on this webinar, and I wish you every success. Thank you.
Thank you, Ms. Karen Thompson, for the positive welcoming remarks. Thank you once again to both our distinguished guests, Madam Sharifah Asian Said Junaid Al Junaid and Madam Karen Thompson, for your profound and significant message. We look forward for your support and expectation in this webinar. We will now move to the second round, the panel of experts. We have invited 4 distinguished speakers to share their experiences in terms of nursing care to fight against COVID-19. Let me first introduce the panel of speakers based on the order of their presentation. Our first speaker, Ms. Hashima Binti Zainul, with the topic Big Data Empowers Nursing Strategies to Fight COVID-19. Ms. Hashima is the Chief of Nursing Officer in University Malaya Medical Centre, Malaysia. She has long working experiences as the Senior Nursing Officer in Critical Care, Emergency Services, and Infection Control Department. takes on many roles and performs actively in various associations such as Chairman UMMC Nursing Club, Vice Chairman MNA UMMC Branch, Advisor Childcare Center at the UMMC. Focuses to improve nursing practice with consistent, comprehensive care approaches and staff management structures. Our second speaker, Ms. Nikki Dennis, Director of Nursing Services, Queensland Jubilee Hospital Metro, South Health, Australia, with the topic, Battle Against COVID-19 from Nursing Perspective. Ms. Nikki, experienced and innovative nursing leader, has a strong focus on patient safety and leading transformational change. A member in different health organizations such as Metro South Health at the Queensland Healthcare Professional Development Consortium and the Association Queensland Nursing and Midwifery Leaders. We also have Ms. Ling Huang, Head of Nurse in Critical Care Unit, Guangxi Medical University Cancer Hospital, China, who will deliver on acute patient care in hemodynamics. Ms. Huang has vast nursing experiences in anesthesia, medication, and nursing management area. Works in wide role involving many committees and clinical organizations such as Guangzhou West Center, Guangxi Nursing Society, and Guangxi Cancer Association. Actively has published more than 30 academic papers in Chinese journal as well as science and technology core journals. Our final speaker in the panel is Niu Hui Ching, Senior Nurse Clinician of Critical Care Unit, National Hospital Singapore. Her topic, the role of innovation and technology in the times of COVID-19. Ms. Niu Hui Ching, currently working as the Senior Nurse Clinician of Critical Care Unit, has more than 20 years working experiences in specialization and a 2 years experience in cardiac general ward. That's the short bio of our finalists. Now we are ready to listen to the presentation of our speakers.
Thank you for your warm welcome. Hello, my name is Nikki Dennis and I am from Queensland, Australia, and I'm the Director of Nursing at Ep2 Hospital within Metro South Health of Queensland Health. So nice to talk to you today, and thank you to the webinar organisers, Malaysia Nurses Association and University Malaya Medical Centre and Mindray for inviting me to share the role of the nurse in Australia's efforts in combating COVID-19. My presentation today will firstly focus on the roles of nurses in Australia, systems in the nurses in health system in Australia and Queensland. Then I'll talk to you about our nurses practice during COVID-19 and then our capabilities in the healthcare profession development training. Metro South is one of 16 hospitals and health services within Queensland Health. We have 5 hospitals with about 2,000 beds and a number of community services providing medical care to over 1 million populations in southeast Queensland. Our doctors, nurses, and allied health practitioners work seamlessly together to provide patient care, integrated care, where nurses play an integral role, as Karen mentioned in her remarks. In Australia, the nurses profession is the largest health profession and accounts for 53% health professionals working in Australia. 90% of nurses and midwives work as clinicians. The rest work primarily as administrators and teachers. In hospitals, nurses care for inpatients in surgical, medical, emergency, diagnostic services, critical care and coronary care, paediatrics and psychiatry. Midwives work within birthing suites and general practitioner clinics. Nurses work with the person's GP and other health professions to develop tailored care plans for management of their chronic conditions. Aged care nurses provide care for the elderly people who are chronically ill, to unable to care for themselves without assistance. Dementia care requires highly skilled nurses. Community care nurses and midwives focus on promoting and preserving the health of population groups and carry out care around immunisation, sexual health, maternal and child care. In Australia, all nurses and midwives must be registered with the Nurses and Midwifery Board of Australia in order to practice. Australia's National Registration and Accreditation Scheme began in July 2010. The scheme was governed by nationally consistent legislation, the Health Practitioner Regulation National Law Act 2009. In Australia, College of Critical Care Nurses, the ACCCN, is a peak professional body representing critical care nurses in Australia. The ACCN workforce standards in intensive care nursing has developed to safeguard the provision and appropriate intensive and critical care nursing workforce to aim to ensure a safe and sustainable workforce that achieves best outcomes for critically ill patients. Intensive care units, there is evidence that the higher ratio of registered nurse staff to patients increase patient safety and improve patient outcomes. The clinical context of critical care nursing in Australia is different to most other nations in both developed and developing world. In Australia, our nurse ratio for ICU is 1 RN to 1 patient for ventilated patients and any other patient in ICU that the nurse in charge deems critically unstable or at risk. 1 RN to 2 patients requiring a high complexity level of care, for example, a non-ventilated stable patient improving from their critical ill state. The professional works and scope of practice in intensive care and critical care nurses in Australia is associated with improved patient outcomes that cannot be understated. And the outcomes of critical ill patients are among the best in the world. The highly quality care related to high quality nursing clinical practice, education and research. The specialist care critical care postgraduate education provides advanced knowledge and skills. Stand up for COVID-19. In early 2020, early modelling for Australia suggested that up to 60% of our population could be affected, with majority of cases possibly mild, 80%. However, this still meant potentially large numbers of severe and critical cases based on these predictions. The first wave of illness at scale was projected to come 10 weeks after person-to-person transmission in the community began. For Queensland, this would have likely overlapped with our winter planning and flu season and was predicted to last 10 to 20 weeks. Absenteeism to increase by 30% due to sick leave, carers leave, and mandatory isolation for a minimum of 14 days returning from overseas, interstate, or confirmed positive 19. The modelling predicted a significant increased demand for our emergency departments and our intensive care departments. The Chief Health Officer of Queensland asked all hospitals and health services to develop and provide up to 3 times their usual emergency capacity and 200 times usual bed capacity for ICU over the period 10 to 20 weeks. And this plan was to occur in the first 2 weeks of March 2020. Capacity planning for COVID-19. We had to stand up a dedicated COVID ward, implement a COVID screening clinic as a hospital avoidance strategy to reduce emergency presentations, doubled the capacity of our ICU. We developed a model of care for emergency management of large numbers of patients with significant respiratory illnesses. We reduced our elective surgery to only emergency in category 1 within 30 days, patients requiring surgery. And we reduced our endoscopy procedures by 50%. and also reduced our specialist outpatients department services, only requiring reviewing Category 1 patients. Nurse staff plan for COVID-19. For my hospital, approximately only 242 beds, we redeployed our nursing staff firstly. We identified our vulnerable nurses and deployed them to low-risk clinical areas. Then we deployed nurses from operating theatres, outpatients, indirect clinical roles and endoscopy to ICU, emergency and clinical wards and the screening clinic. This was a total headcount of 110 nurses. We increased our FTE by increasing part-time staff hours by 15 FTE, employed more temporary and casual nurses by 10 FTE, and increased our new graduate nurses by 10 FTE. And we also cancelled holidays up to 5 FTE. In total, this provided an additional 140 to 150 FTE for nursing staff to the critical care and ward areas to support the COVID response. Training priorities for nursing for COVID-19 within our hospital was on COVID-19 education, COVID-19 swab screening, PPE procedures, donning and doffing procedure, invasive ventilation, non-invasive ventilation, arterial line management, CVC management, patient suctioning, emergency and resus upskill, medical and surgical cross-skilling, IMR training and reskill, and team and functional nursing models of care. The current practice for patient care is nurse allocation, 1 nurse to every 4 patients morning and evening shift, and 1 nurse to every 7 patients on a night shift. However, due to the predicted number of staff availability, models of care needed to be adapted to ensure patients and staff were safe, providing adequate care. Team nursing involves several team members working together to deliver comprehensive care to a larger group of patients than would usually be allocated to 1 single nurse. Different team members are delegated different aspects of care, aligning with their scope of practice by the team leader. Team members are not limited to 1 specific task or activity, rather they may perform a variety of tasks on several patients. Functional nursing. The principle of functional nursing is required functions, tasks or activities are dedicated to a specific team member for all patients in the workload. This differs from team nursing, where multiple team members might perform the same functions, but on different patients. These new models of care were supported by the Integrated Electronic Medical Record, IMR. Our strong workforce and digital innovation support roles of nurses. It provides linkages to critical care and operational and corporate. Digital hospital systems are proven to improve patient safety in hospitals in Australia and overseas. Measurable benefits in a digital hospital include reduced adverse events due to medication errors, pressure injuries, and faster response times for deteriorating patients. There is a real opportunity with the introduction of IMR to support safe, sustainable patient cares each and every time. The IMR system functionality has programs built in within it for nurses to complete a comprehensive risk assessment, initiate a plan of care, and order cares 24/7. Step 1, assess care. Step 2, initiate care. Step 3, order care. The key to the success is force functions, IMR and workflow education, and understanding the why, addressing culture and ingrained practices. The fourth function. This 3-step process is mandatory for all patients to have completed pressure injury, falls and malnutrition risk assessment planner care, and a minimum set care orders with customised cares for specialty areas. The benefits: improved patient outcomes and safety, improved time management for nurses with proficient new improved clinical documentation. Improved care for hospital-acquired pressure injuries for unstageable pressure injuries. It is evident from the data of improved patient outcomes and care from pre-digital implementation to post-implementation and the sustainability of the desired outcomes. And also the evidence here demonstrating the improved patient outcomes and care from pre-digital implementation to post-implementation. To enhance and support the clinician's decision-making using the IMR, Queensland has developed a number of functional dashboards for operational and clinician decision-making. Here are some examples of 9 clinical dashboards, which are real-time data to help clinicians to care for their patients, which result in better health outcomes. Operational decision-making dashboards. Over 10 dashboards with strategic and trending, performance and operation monitoring, and have a variety of data sources, including IMR, hibiscus, pathology, radiology, and manually collected data. And each dashboard has multiple tabs and views. The governance, there is a clinical ownership for each dashboard governing access and appropriate use, and the security has a Novell login for each staff member. Our clinical excellence developed dashboards and implemented them into business as usual and won the eHealth Award. Here is an example of the real-time dashboard monitoring patients' triggers for deterioration. The benefits and innovation in COVID-19. Staff development. Due to COVID-19, we now have increased number of nurses with critical care training and experience, supporting backfilling for ICU staff, sick leave and annual leave. We have developed an in-house ICU rotation program and have increased critical care skills within our ward areas. And we have also increased our cross-training of nurses and also increased an uptake of our nurses enrolling in postgraduate studies. Overall, we now have a higher level of skilled and educated nursing workforce caring for our patients. This slide shows the different pathways for a career in nursing and midwifery. A student can enter a technical and further education college or a university depending on their level and grades. TAFE graduates with Certificate 4 and become an enrolled nurse. They also earn credit points towards Bachelor of Nursing in universities. The university degree allows registration as registered nurse or a registered midwife. Once registered, a nurse may want to further the studies to become more specialised or a nurse practitioner. After this, there is a possibility to do a master's degree or a PhD degree in nursing. Some of the areas that a nurse may specialise are aged care, mental health, paediatrics, immunisation, cancer care, endoscopy care, emergency, critical care, rural and remote, and education and research. Given the quality of the healthcare education, accreditation, and professional development standards in Australia, and the response to the demand for internationally competitive professional development programs, the Queensland Health Care Professional Development Consortium was formed in 2018. Led by Queensland Health, the consortium includes 3 public hospitals and health services, 7 universities and TAFE Queensland, and draws expertise from all aspects of health policy and practice, health, medical and clinical research, and on-the-job learning through the involvement of doctors, nurses, and allied health professionals in Queensland hospitals and universities. The consortium was engaged with various markets for executive training programs, including China, in areas of hospital management, digital health, radiology, general practitioner, and clinical research to international groups, including Guangzhou and Shanghai. Queensland's capabilities in nursing services and research are highly recognised. We are having conversations with our international partners on collaborations in nursing clinical services, education and research for better health outcomes for our communities. We look forward to working with you to exploring these opportunities. Thank you again to the webinar organisers, Malaysian Nurses Association and the University of Malaya Medical Centre and Mindray for this opportunity to share with you our education, services and technologies in nursing and how we mobilise the resources to battle against COVID-19. We are happy and keen to share with you and learn from each other of our experiences and know how to provide better health to our people. I look forward to your questions at discussion time. Thank you.
Thank you for the interesting presentation. Ms. Nikki focused on how planning and deployment of nursing staff are crucial during the pandemic, the need for training for nurses in priority areas such as COVID-19 education, COVID-19 swab screening, PPE procedures, resuscitation upskills, invasive, non-invasive ventilation, in-house ICU rotation, and others are essential. Once again, thank you, Ms. Nikki, for your sharing. I call upon Ms. Ling Huang to deliver her speech.
Our cancer hospital is specialized in treatment, clinical practice, clinical disease prevention, and nursing. We are a provincial level cancer hospital, and we are also a AAA hospital in China. Thank you for being invited to be here to join this meeting. And I'm very honored to meet all of you and to share my insights with all of you. As we all know that the year of 2020, after the joint efforts of our individuals, we will be able to help to take care of the work. And now in China, everything's being well contained, and we go back to the normal track of our daily life. So that's the reason today I'd like to share with you the detailed nursing for the hemodynamic monitoring in the critical care patient.
Whether it's the fluid resuscitation or mechanical ventilation, we cannot go without the hemodynamics treatment. And in every stage of the treatment, we need to assess the hemodynamics to actively guide the method, strength, and also the intensity of the treatment. And the sepsis. Sepsis is a life-threatening organ dysfunction due to host response dysregulation caused by infection. This definition was given by American and the European Society of Critical Care Medicine. And the emergence of this new definition has had a very important influence to the clinical decision-making together with accumulation of clinical evidence. In the early identification and the proper treatment can improve the prognosis of sepsis. As we have diagnosed sepsis according to the 1-hour bundle treatment strategy proposed by Surviving Sepsis Campaign 2018. We should evaluate the serum lactic acid level and to use the antibodies before to conduct the blood culture, and also to have the anti-infectious treatment, and also to implement the fluid resuscitation and to apply the vessel active drug. And a vessel active drug is actually a regulate the is a medicine that regulate the vasomotor state, and they maintain the stability of hemodynamics, and in which the norepinephrine is recommended by the guidance to as the frontline drug to cure the sepsis. However, the vasoactive drug application can cause many adverse events. For example, like the arrhythmia, etc. The incidence rate is 10 to 72%. And however, the reverse impact influencing factors are intragenetic and also the patient factor. We're talking about the intragenetic factor, for example, like the non-specific consumables. And normally for the infusion pump of each brand will have a dedicated infusion syringe and a tube before pump. However, because the price is relatively higher than the consumables, and many hospitals will use the non-specific consumables, the elastic and inner diameter are different, which will influence the accuracy of the infusion speed and also the drug absorption. Because in our clinically widely used is the infusion set, infusion syringe, or the PVC materials, and it can have the absorption to drug, and the material absorption may influence, in fact, the blood concentration. So first of all, as an ICU nurse, and also as the user of the vasoactive drug, we need to learn the pharmacological action to improve our awareness. For example, like the norepinephrine is improving the MAP through the vasoconstriction, which has a relative influence to heart rate and stroke volume. The dopamine is to improve the MAP through increasing the heart rate and the stroke volume. And compared to the norepinephrine, the dopamine has a higher incident rate of arrhythmia. And the ICU pump control medication is verified, and it has different adaptation disease, which will have a huge side effect to vasoactive drug. The corrective use is a matter of life-threatening, life safety of patients. And to some new nurses, it will be a huge test. So in our department, we will put the card on the hanging tower. On the card, you'll have the conversion method in the drug pumping speed and the dose. And while we infusion the vasoactive drug, it has a higher requirement, because the concentration is high, the irritation is high, and also the infusion time is long. So while it has a higher requirement to the vascular condition, if we choose the peripheral, for example, like the large dose infusion of dopamine, which will cause the peripheral vasoconstriction or vasospasm, and ischemia, hypoxia, or the vascular wall permeability increase, or the drug will penetrate to the tissue space, so which will cause the image damage or necrosis. So in our department, we prohibited the use of peripheral vein for the vasoactive drug, and so that is why we don't have the situation like what we're seeing in the previous pictures. In our department, we usually use the double lumen or the triple lumen central venous catheter when it's easier for the fast fluid resuscitation, and then it's more the safe infusion. And so this graph shows that when the nurses have the catheter and a lumen assignment, and the vasoactive drug is infusion through the cycle, and which is using the same lumen with the carrier liquid. Actually, blood pressure is the easiest method and important for the hemodynamics compared to the non-invasive blood pressure. The invasive blood pressure can continuously monitor have a more accurate and a more timely active blood pressure. In 2018, China sepsis guidelines suggested that all patients with the vasoactive drug in need of implant artery duct to conduct the continuous blood pressure assessment. However, we do have our confusions because some patients has a large difference for the systolic pressure and the diastolic pressure. And how should we interpret this difference? Some reports has already showed that in the normal range, there is no huge difference between the non-invasive and invasive blood pressure. However, for a hypertension patient, the non-invasive blood pressure is underestimated the actual pressure, and for hypotension patients, the non-invasive blood pressure is overestimated the actual patient. These and so some studies told us that the map of invasive and non-invasive blood pressure is relatively consistent. And also for the cardiac output and the mean arterial pressure is two very important components for monitoring the hypodynamics. Through fluid resuscitation, increased septic shock patient, the cardiac preload to improve the CO. So for the norepinephrine to increase the MAP through vasoconstriction, the guidance requirement target is 65 milligram Hg. The application, the reaction of MAP is tissue perfusion state. And so the vasoactive drug, the half-life is only 1 to 2 minutes. It has to perfusion through the perfusion pump. And however, it is actually the guarantee for the continuous and stable and accurate drug perfusion. Look at this picture that you will see that through the invasive blood pressure monitor, we could see that an improper method of changing pump will cause the fluctuation of blood pressure. So clinically, in the uninterrupted pumping, it is easy to cause the adverse events. And in China, we have many methods of changing pump. However, there is no unified quality control standard, which has already caused potential risks for patients with accepting the infusion pump. For their micro injection pump has 3 delays: the startup delay, blockage alarm delay, and the infective lumen of intravenous catheter delay, which will influence the hemodynamics. And in order to solve the above mentioned issues, we do have some nursing experts in the early stage to start to focusing on the changing of pump to reduce the change of hemodynamics. These 2 photos are the 2 connecting methods of pump tube in our clinic status. And in our department, we will use the combination pump with a relay function. So first of all, we will set the 2 perfusion pumps relay function. We will set up the relay function of the 2 perfusion pumps with vasoactive drugs, and also to install the syringe with prepared same concentration of drug on the second perfusion pump, vent the air, and also connect the pump tube to the T-shaped tube and open the T-shaped tube to ensure the 2 pumps are connected. And when the first pump, the drug in the first pump is nearly finished, the second pump will automatically activate the relay function to finish the drug change. In our department, we integrated the monitoring device and the infusion pump information to the nurse monitoring station, and at nurse station we can see the information and alarm, and so our nurses can prepare all the drugs in advance when showing the remaining, when seeing the remaining time of the drug infusion. For the clinically ill patient, normally they may require multiple drugs for the continuous intravenous pumping. So for different drugs, for using the same intravenous pathway, with using infusion with different tube. So we use different color marks to categorize all the drugs, and also the color on the catered to will be the same as the perfusion pump on the backside, which is easily for us to identify the high-risk drugs. So in summary, whether it's the European or American sepsis guideline, the 3-hour bundle or the 2018 1-hour bundle, they have always been the core strategy for the surviving sepsis campaign, which emphasize on the early active treatment and to apply the fluid resuscitation as soon as possible and use the vasoactive drugs properly. For example, like the neuroaprophyrin dopamine and the dobutamine, etc. The half-life is short, concentration is high, irritation is high, and the infusion time is long. So we need to prepare the detailed management can maintain the stability, continuous and accurate infusion of all the drugs. So all these cannot continue without the professional care provided by the nurses. So our nurses has to continuously study the new guidance and to use the knowledge update to bring the progress in practice, to focusing on the cooperation between different medical staff and to have a high effective communication. And I hope that as a nursing management in the department, I hope that all the nurses can receive the all the patients can receive the professional nurse service. And lastly, I wanted to thank the MNA, Malaysian Nurses Association, and UMMC and MIRE for giving us this high quality international academic exchange platform. Thank you very much for your listening.
All 4 speakers have shared their working experiences and indeed gave more guidance and references for all clinical audience. Let's thank all the speakers. We shall now move to the much awaited session, the panel discussion. As mentioned earlier, audience can pose your questions in the question and answer box. Your questions will be actively answered by the distinguished speakers. Okay, there is a question here for Ms. Nikki. How often screening done for nurses involved with COVID-19 patient, and how often do you all do it?
I've provided the answer for those online. Our nurses working with COVID positive patients are tested weekly or earlier if they have any symptoms.
Okay. Ms. Hasina, would you like to add on to that in UMMC?
Okay, thank you, Ms. Yoga. So in UMMC, every day we have this system which has admissions through visa. So we sort of like screening them in our front door itself in terms of temperature and their exposure risk, and also whether they have red visa or not. If they have red visa, they will be sent to ED or to our special staff clinic to be screened and to be swabbed. So that's how we do screening for our nurses, and especially when they came from the red area, red zone, so therefore we need to screen them. And in our special staff clinic, where we will accommodate for all the nurses who have symptoms. Let's say they have fever, they have diarrhea, they have URTI symptoms. So they are prohibited from entering any units or wards or clinics. So they will be sent to this special staff clinic to be screened and to be swabbed and to be given leave until we have proven that they are not COVID-19 positive. That's how we screen in UMC. Yeah, thank you.
Thank you, Ms. Hasima. There is also another question to Ms. Hasima. Are nurses paid overtime or special allowance or extra annual leave during this pandemic for those especially working in COVID ward?
Yeah, as we know in Malaysia, Ms. Yoga also knows this, that we whoever work in the COVID-19 area, mostly in public hospitals or in training centers. So we are given COVID-19 allowance, which we be paid of how many days that they are contacting with COVID patients in the screening area, in the wards, as well as in the clinics. Whoever we are contacted or we are
nursing a patient with COVID-19 or probably COVID-19 patient, they will be paid an allowance. That's what we do. And in our setting, that we give them foods as well for all the nurses who are working in the general wards and also in the ICUs. So that's the support. And also I would like to add that we give them accommodation for them also if their house is far from the hospital, so we accommodate them and we have a quarantine center for them if they need one. I think that's the support that we give, part of allowance.
Thank you, Ms. Hasima. Ms. Hui Ching, would you like to add on to that in Singapore? How is there any allowances or overtime given for the nurses who are working in the COVID-19 units?
We don't get our nurses to do overtime. So far not in that situation yet. But we have very kind sponsors in Singapore whereby they sponsor food and drinks for the nurses. So all these are actually distributed by our nursing department. They will allocate every day, during that period, we have burgers, we have drinks for high-risk area, as of course in Gen Ward also we do get. So these are some kind appreciation from the public itself. Yeah.
But there is
the allowance and everything remain the same.
But any special allowance?
No special allowance.
Oh.
Yeah, from the hospital. Yeah.
How about in Australia then, Ms. Nikki?
In Australia, we don't have a special allowance for COVID-19. We've got a very strong award. And again, we pay all our nurses overtime if they work overtime. However, we try and avoid overtime to ensure our nurses are well rested and there's no fatigue. However, our state government of Queensland did provide every frontline worker in nursing 2 days annual leave, extra on top of the award as a bonus for the stand up for COVID-19.
This looks interesting. Can I have input from Ms. Ling Huang? How about in China? Do you have any overtime allowances paid, special allowances paid for the staff working with the COVID-19?
我们在中国的话是没有加班费的，然后的话每班的话只是四个小时，就保证足够人员的更换。但是因为这个事情的话非常久远了，我们是在2020年的，就仅仅用了2个月多的时间就把这个疫情控制住了。这样的话，我们大部分的人我们原来驰援武汉的这些医护人员团队就回来了。实际上现在都是回归一个比较平和的一个状态。但是回到我们本土的时候，就回到我们自己这个资源的这个城市，这样的话，我们医院就给了一个比较巨型的，应该说应该很多的一个资助吧，奖励他们，鼓励他们在这次新冠疫情做出的一个巨大贡献，非常非常的丰厚。然后在一些政策方面，比如说晋升等方面，也给予很多的支持，我们都感到非常自豪。
Thank you for the answers. We also have another question here regarding this. Are there any challenges to operate the electronic devices, example, the electronic medical record? This question is posted to Ms. Nikki. Ms. Nikki, can you take up this question?
Yes, I can. Again, our nurses are well trained with the electronic devices. When we introduced our electronic devices here in 2018, we thought our older workforce would struggle with that, but we found it was quite the opposite. They are actually very confident with it and are very keen to uptake it.
I think this question is also related to Ms. Hasima. The nursing staff needed training on the current situation on this using this big data?
Yeah, you are very, very true. That's very big challenges, not only in terms of impact in the big data and also in electronic medical record, but as well as the very important part is the quality of the data that being input in the system. So a lot of training that has been done through online to the nurses, to all the ward managers, and even to all the matrons. So I think it's a very big challenges, but we are still in the training part of this system. Yeah.
Okay, thank you. There is also another question here asking on how to manage the infection control in the COVID-19 floor. And this question is directed to Ms. Nikki.
On our COVID-19 ward, we actually employed more nurses for more ratios, and we actually had a nurse role, which was a spotter role. And that nurse role was primarily to monitor all the donning and doffing when nurses or any healthcare worker was providing care to the COVID-19 patients or patient screening for COVID-19 to ensure that there was no cross-infection. Also, we had increased education with our donning and doffing, also our hand hygiene. We also increased our hand hygiene auditors to be out there on the floor as safety checks to ensure that there was high compliance. And we also limited the people going onto the COVID-19 and had our core staff working in that area. PPE was provided to non-clinical and clinical staff, and that was refreshed regularly throughout the shift, so they didn't wear the same piece each throughout the whole shift. And we also now, because we did have a COVID breach of a staff member contracting COVID-19 from a patient at another facility in Queensland, we're now doing fit testing. It's a nurse-led clinic here at my hospital where we're testing all the masks to ensure that they have no leakage. And so we've got around 500 nurses we have to test around that.
Thank you, Ms. Nikki. Anybody else wants to add on to this? How to control the infection control?
I would like to say something. I think the most helpful things that, because we cannot control humans' behavior, so we have a problems of non-compliance and adhere to all the infection controls in the wards as well in their rest area. So what we do is every shift that we have a COVID enforcement officer, a part of the infection control nurse, whereby they go rounds and they do this prompt teaching. Also, they just educate whoever who doesn't comply. So some of them took photos as evidence, so that we retrain all the nurses, all the units that we found that have lack of these infection control measures. So that's what we do in UMFC.
Thank you, Ms. Hasima. To Ms. Hui Ching, there's a question, how to make sure the diagnosis and prescription when a patient's on teleconsultation?
So for those patients who are on teleconsultation, there is a set of criteria, okay, to enroll this patient into teleconsult. Mainly they are the more straightforward cases, simple cases, not that complicated with minimal premorbid. So this group are easier to manage during teleconsultation, if I get your question correctly. Yeah. And then the prescription will be those patients, as in, if they are straightforward, the medication will be relatively straightforward, dual antiplatelet, and those necessary medication required for a straightforward kind of acute myocardial infarct patient. Yeah.
So how do they collect the medications? Is it posted to their houses?
Yeah, they can request for delivery to be sent, or a prescription can be given to them and then they can collect it at the hospital itself. Either way, yeah, that can be done. That can be arranged.
Thank you. Related to the same question, we have another audience asking for remote cardiac rehabilitation, how to protect patient safety during the exercise program.
Okay, so
alone at home.
Yeah, correct. So they still get patient to do inpatient exercise in the hospital itself, but those that are at home, we will need to enforce to them there is no real-time monitoring. And of course, with no real-time monitoring, we will advise the intensity of exercise at home. So it will be more of those simple stretching exercise instead of those high intensity kind. Those with more high intensity, they will have to do it in person in the hospital itself. Yeah.
There is another questions coming up here. To Miss Huang, when you're using the multi-channel pump, is there any negative or positive effect towards central venous pressure? Miss Ling Huang. When you're using the multi-channel pump, is there any negative or positive effect towards central venous pressure?
没有。然后我们就使用这个泵，我们能够完成我们血管活性药物的一个输注。然后可能我对这空气方面的这些研究没有太这方面的一些经验。
Thanks. Okay, but under the replay infusion mode, what are the drugs that is suitable? If I'm reading directly the question from the audience, under the replay infusion mode, which type of drug is suitable? Relay mode, I mean relay mode.
对，就是说血管活性药物的输注，我们肯定是用输注泵。然后现在我们使用这个，也就是迈瑞公司这个输注泵，它有一个叫中继功能，它就可以能够在第一个药还没有使用完的时候，我们就把第二个泵送上去，续泵上去。这样的话呢，它的药物就能够一个无缝隙的一个对接，然后避免了血管活性药物造成的血流动力学的一个波动。 能够很好、比较稳定的、持续的、精准的输入。
Now the question is, which type of drugs is suitable for this infusion pump, for the relay mode?
就是一般我们选择是 双腔或者是3腔的中心静脉导管去进行血管活性药物的输注，我们会选择侧孔去输注这个血管活性药物。主孔的话，我们就会比如测 CVP 啦，或者一些大的液体做液体复输，我们会选择在主孔。
Can I add on, Ms. Yoga?
Yes,
I think the type of medication that we use for using what Ms. Huang Ling has mentioned will be mainly more of those medicine that are more sensitive to our hemodynamic, mainly the vasopressor, inotrope kind of like dopamine, yes. Dopamine, noradrenaline, whereby patient can be very sensitive. That is why we need this relay thing to kick off without interrupting the treatment. Yeah, if that to add on to Huang Ling.
Yeah,
answer.
thank you.
Yeah, thank you.
There is also another question. How to avoid multiple exposure to COVID-19 patients? Any one of you can take this question. How to avoid multiple exposure to COVID-19 patients? I think this is related to nursing staff. How to avoid multiple exposure if you have to work?
Okay. Can I answer that?
Yes.
So in our setting, how can we control that is by we should screen the patient also. So in our emergency department, whereby we screen patients who have symptoms or who have high risk exposure of COVID-19, so we separate him from the normal patient who have no symptoms. So starts from ED, so we have a respiratory area in a resuscitation room. Also, we separate him within a non-risk patient with a high-risk patient with symptoms of respiratory. So when the patient went in this high-risk area, like respiratory area, whereby usually we screen the patient. So we will isolate them. If they will be admitted to the ward, we will isolate them in the room until the swab results come back negative, so that we de-isolate them to the normal ward. Is so that we will minimize the exposure of the nurses, so that we know this is a dirty area, this is high-risk area, so the nurses there will wear PPE, so it will avoid multiple exposure to the nurses. So in the ward itself, when the patient came in for elective surgery or emergency surgery or semi-emergency surgery, we will screen them also for COVID swab. And then when they are negative, we proceed with the operation. So every patient who are at risk, when we are doing our AGP procedure, will be screened, especially patients for general anesthesia that we need to intubate them. So we need to screen them, whether by rapid test or by PCR, so we know that the patient status. So that will reduce our nursing staff being quarantined or being exposed multiple times. And that's what we do.
Ms. Nikki, would you like to add on? I see
yes.
you're...
In Australia, we had a very similar response to that. When patients presented to our emergency department, we had a clean area and what we called a respiratory area. We diverted our patients that had symptomatic COVID symptoms to the respiratory area where we tested those. We had a dedicated group of staff in that area. We also, in our clean area, our staff also wore PPE for the fact that we could not say that patients didn't have COVID even if they didn't have symptoms. So all staff were in PPE throughout the whole hospital, even the non-COVID wards. If we needed to admit a patient for surgery, for emergency surgery, we would do a short-acting test for COVID prior to surgery because we didn't have the facilities of a positive or negative pressure room in our facility to ensure that we screen them for COVID so we didn't cross-contaminate there. Also for our ICU patients requiring ventilation, any COVID positives that we tested would go to the tertiary hospital within our facility to look after those.
Thank you, Ms. Nikki. There is one question posted directly for Ms. Huang. What are the standard treatment given to positive COVID patient in China since you only took 2 months to be back to normal? Ms. Huang?
现在如果发现一些散在的病例的话，我们可能就是还是让他居家隔离。就如果发现的话，如果是境外的话呢，可能我们有个指定一个地点的酒店，然后他在酒店里面隔离，然后直到核酸检测阴性，可能3次以上，然后才能够去解除隔离，回到我们的生活当中。
No, during the pandemic, the Wuhan pandemic, what was the standard treatment given to the patient?
这个当时的话可能是比较当时不叫标准吧，因为现在已经是出了第8版了，我再把当年的这些标准拿出来谈可能不太合适，因为我们标准的第8版呢，我们是今年的2021年的4月14号才出来，所以现在具体的情况、具体的标准的话我没有看，我只能是这样说了，因为我们已经早控制了，现在已经没有接触在这样的病人。
Okay, thank you, thank you. Coming back to Ms. Hui Ching, was there any problems in Singapore on rescheduling of appointments towards hospital?
Oh yes, they have a lot of backlog. So appointments were rescheduled. Those we can do teleconsultation, we will do teleconsultation. Those which require review, it will be rescheduled if they can wait. So at the end of the pandemic, the doctors has actually a whole long list of patients, and clinic will have to also extend on weekend to see patient to clear all this backlog. Yeah.
Were there any complaints or insatisfaction from the clients for not being able to come?
I think not that I know of. in general, everyone do know that there is this constraint during this pandemic, so they were rather understanding. Yeah.
Thank you. Ms. Hasima, how about in UMMC, the rescheduling of appointments? Did they overcome any problems there? Rescheduling.
Yeah. We are the same with Singapore, so with switching that we use hybrid. So patient came, like 50% of patient came, and we don't reschedule patients who are oncology patients, or patient with cancer that needs prompt treatment. But however, other patients that we do reschedule, and some of we meet them through telemedicine and teleconsultations also. It's the same. Yeah.
And there are many attendees have posted this question: how to deal with lack of staff in facilities? I think any one of you can take this question. Lack of staff.
So in Australia, we didn't get hit as much as the overseas facilities did. However, in my presentation, we were predicting to have 30% absenteeism. So that's where we actually deployed our nurses into other areas, and then also increased our part-time, employed more casuals, and increased our nurse graduates, and cancelled our annual leave to increase our workforce there. In Australia, that's what we did to deal with that. But also the models of care that I put forward was the functional model care was to deal with if we had didn't have enough nurses or registered nurses to attend, that we could get any scope of practice nurse, whether that's an AIN or allied health worker, to work with us under the direction of an RN to provide the care through the IMR, which was the cares that were ordered through IMR. So that's how we were planning if we had a big absenteeism, but we were fortunate that we didn't have to go that far.
Ms. Hui Ching, would you like to add on? How to deal with shortage?
Yeah, shortage of staff, I think is quite common. We have staff calling in MC every now and then. So how do we manage it? During the pandemic itself, like what I have mentioned in my presentation, we have actually ran out a group of nurses from general ward. They attended this critical care crash course, and this group of nurses can actually be deployed to the critical care area as a pair of helping hands to manage if we really run into this type of influx of patients. Otherwise, on a daily basis, shortage of manpower, we get deployment across the intensive care unit. So we will just send out text, oh, we have MC today. Is there which unit which can spare us extra staff? So usually, yeah, we do get deployment, because sometimes when our unit has high acuity, the rest of the ICU has low acuity. This is how we balance it out. Yeah.
Anybody else wants to add on? Okay, one last question maybe. During this pandemic, actually, how do we counsel our nurses? Because they are actually burnt out. Yes, they are mentally can't work. So how do we actually manage them?
Can I give some input from in Singapore? In my working hospital itself, we have this counseling and wellness clinic. So we are always the management always encourage us to send staff who have burnout symptoms or need someone to talk to during this period of time to attend this clinic. So there will be counselor there to help them, and then to listen to their concern, and of course some ventilation. Yeah.
Yes, Ms. Hasima, I saw you putting up. Yes.
Yeah. So I think talking about shortage of nurses, as well as we can see that most of our nurses were burnt out and tired because we have the whole year of battling with COVID-19. And what we do in our hospitals is that we have a psychological first aid whereby firstly we will look into their well-being and wellness first. So the nurses who are pregnant, who have a comorbidity, and who have they have a parents who are very sick, that putting them a higher risk of contacting COVID-19. So we put them in a non-COVID area, so to reduce their anxiety in terms of working in the COVID area. And for nurses that we provide a place for them during quarantine, provide foods and provide support psychologically, and whoever burn out or cannot sleep or turns out to be depression, so we will refer them to the psychiatrist to get them being medicated. And as far as I can see, the nurses being deployed in each unit or to a COVID area, they will turn out to be quite anxious and anxiety. And in terms of that, the unit manager plays an important role in giving counseling and to detect and observe whether they have problems in terms of daily activity of the nurses, to look into their welfare, their safety, and also their wellness as well. So that's what we do in UMMC. Then, and we have also, if the nurses turns to be burnt out, so they will be deployed to a lesser activity area. So they will have non-COVID days and COVID days. So therefore, we can reduce their burden, or so they can have their rest days. But most of them are very tired now. So I think that's the things that we managed to help them.
Thank you. I see Ms. Dicky, you want to add on?
Yes, at my hospital, again, it's a very good question in regards to how we look after a nurse's wellness. And again, it shouldn't be something a pandemic should make us do. It should be something that we do all the time. Nursing gives so much of their time and also sacrifice so much of their life to provide to the community. So just of recent, I met with my senior nurses here at my hospital to work out how we can actually provide a wellness program to our nurses and promote how we give to each other and look after each other as a profession. International Nurses Day, I launched our wellness program with a lovely card for all our nurses, thanking them for their extraordinary efforts. And on that card was a little chocolate disc, and that had a QR scanned, and that QR scan linked them to our nursing and midwifery support service. It's a national service that we have here in Australia 24/7, and it's got all these wonderful resources for tips and tricks in regards to sleeping, eating, drinking. If they're having trouble, there's a counsellor that they can talk to, and then they will refer them on to the appropriate medical practitioners if they need further advice. That is a confidential service, and that is paid through our registration that we pay each year as our nursing registration. We're also at my hospital, we're looking at different programs, how we can actually socialise more as a profession outside of hospital to relax and ensure that we all have that life and work balance, and actually get to know each other outside the facilities, because that's where all the good stuff happens.
Thank you. Thank you for the answers. We have no time because we already exceeded 15 minutes. So thank you all speakers for your wonderful input. From this panel discussion, there are a few points to ponder on. Technology as the helper cannot replace critical mind, compassionate hands, and warm hearts of the nurse. All the essential elements must be interlaced with technology and innovation for better outcome of the patients. Thank you once again to all the amazing speakers. We have come to the end of our webinar. As for the closing, addressing improvement in nursing workflow are essential to improve nursing interventions. And a key to success is to find the right balance between information science and nursing science. Innovations in human technology interaction can be used to support nursing professionals in patient care to improve the performance, coping skills and mental stability. Technology and innovation enhance the nurse-patient relationship, as well as the ability of adequate time by increasing quality and positive outcome to the client. In relevance to the pandemic, COVID-19 emphasis on the value and benefit of technology to combat COVID-19 are crucial. The benefit of modern technology cannot be overwhelmed. Human touch need to be there. As nurses, you are the only person being there when breath becomes air. Thank you to the organizations for this webinar, Malaysian Nurses Association, University Malaya Medical Center, and MINDRE for providing this platform to gather all guests and participants. Thank you to our guests from Malaysia, Madam Sharifah Asia Said Junaid Al-Junaid and Ms. Karen Thompson from Queensland Health Australia. Thanks to wonderful speakers from Malaysia, Singapore, Australia, and China for the outstanding inputs and references. Finally, thank you to all audience for staying tuned with us on this webinar for the past 2 hours on a Saturday mid-morning. I hope this kind of activity takes place regularly as together more practitioners and share their expertise and experiences with clinical nursing staff to help them work better under the COVID-19 pandemic.